As Floyd said, we're going to discuss primarily shoulder injuries and prevention, as well as treatment. And we'll just move right along here.
Can you use the microphone?
All right. Yep, I can do that. I can just lay this here and tap it. Okay, so
It should be on. You just have to be close to it.
check. All right, cool. All right, so we're going to briefly go over the anatomy first, the shoulder anatomy. This is the, oops, there we go. Scapula, humerus. The scapula, the in view. This is where the scapula interacts with the humerus, right there on the humeral head. This is normal anatomy as it is, as it articulates with the skeleton. You will notice that the scapula and the humerus, the only direct link with the bony skeleton is the clavicle or collarbone. Everything else is muscle attachment. So this is the labrum. The actual bony part of the articulation with the humerus is very small. It's about that big, about silver dollar size. And the rest of that interaction is formed by the labrum, which is a cartilaginous structure that surrounds the bony part, and that actually forms the cup that the humerus interacts with. And then around that we have this is the joint capsule, which is a fibrous tissue, ligamentous tissue that surrounds the humeral head. It has some laxity to it to allow the motion the shoulder has. And then this right here is the long head of the biceps that actually attaches to the superior aspect of that cartilaginous labrum there, and can really cause problems. We'll discuss in a bit here. As far as the rotator, I'm sorry. As far as the ligaments, this is the posterior view, and you can see that the joint capsule just kind of surrounds the bony articulation there. These are the extrinsic muscles of the shoulder. We have the pectoralis major here. Then we have the levator scapula here. They interact with the levator scapula interacts with the scapula, holding it kind of in a position so it can't be extended outward. The pectoralis attaches to the proximal part of the humerus. The latissimus attaches to both the inferior aspect of the scapula as well as the humerus, and attaches to the bony skeleton from the spinous processes all the way down to the top of the pelvic bone. It's a very broad muscle. The prominent aspect of the shoulder is the deltoid muscle. It forms the round curve of the shoulder, and is responsible for the early part of the extension of the shoulder. I'm sorry, abduction. There we go. So the deep muscles, we have the serratus. Oh, this is teres minor. Jesus. Pectoralis, pectoralis minor, sorry. And then we have the posterior aspect. We have the rhomboids and the trapezius muscle. This is serratus muscles. They attach to the inside of the scapula, important stabilizer muscles, and then they go from the ribs to the anterior aspect of the scapula, which is sort of the part between the scapula and the ribs. Again, another important stabilizer. And the last of the intrinsic deep muscles we'll talk about is going to be the rotator cuff itself. We have the supraspinatus, which does this. The infraspinatus, which does external rotation. Then we have the subscapularis, which goes underneath the infraspinatus and attaches to the other side of the scapula, the front side of the scapula. That allows you to push this way. And then we have the teres minor, which allows internal rotation. The rotator cuff basically functions to hold that humeral head into the socket, so that you have the motion that you can have with the shoulder, which is the most motion you have in any joint in the body, but it requires this articulation of these muscles, the strength of these muscles to hold it in position. Another view of the rotator cuff, kind of color-coded here. This is the supraspinatus, infraspinatus, teres minor, and subscapularis. Okay, so common shoulder injuries in paddlers. We have, I should have brought my glasses. All right. We have tendinopathy, which is tendinitis or tendinosis, muscle strains. That's an acute traumatic injury, or can be from chronic overuse, tendinopathy as well. Ligament sprain, which is always acute traumatic. We have tears that can be either acute or chronic, ligament or muscle, subluxation or dislocation, and fracture.
Hey Wes.
Yeah.
So I'm thinking about the layman's terms here. Like, is tendinopathy the same as tennis elbow?
Tendinopathy would be tennis elbow because it's more of a chronic condition.
Yeah.
Tendinitis is thought to be more of an acute condition, although they do cross over and blend.
Okay, so
but when you think of
is that, but then like
right.
More than.
Yeah, since it's more of a chronic overuse as opposed to acute injury, it would be more of a tendinosis.
Right.
Hey Wes, you're tangled up in your cord and you're stressing me out that you're going to pull your iPad off the phone.
Ooh, thanks. Important safety tip. All right. So tendinitis, inflammation and micro tears due to acute overload. Tensile force is too heavy or it happens too fast. Tendinosis tends to be a degenerative problem from overuse. Tends to be more of a chronic condition. And it tends to happen when folks do the same thing over and over again, but don't give it time to heal between these little micro injuries, and so end up getting an inflammatory condition that tends to be chronic and very difficult to deal with. Okay. All right. So tendinopathy prevention. You want to have good technique to avoid strain. Strength is important. Warm up is important. Stretching is important. Treatment of tendinitis is the classic RICE, rest, ice, and non-steroidals can be beneficial. Ice is important acutely after the injury for a couple of days, but also for flare-ups along the way. You go do something and your tendon flares up, then you ice it afterwards, very beneficial. Non-steroidals, oral and topical. The Voltaren or diclofenac gel is the new hot topical on the market that a lot of people are having good benefit with. Tendinosis, as we discussed, is like the chronic conditions. For treatment of that, you want to try to protect it from further injury. The more you aggravate it, the worse it's going to be. Ice after you've aggravated. Aggressive massage, and this is a device I really like. You can get them on Amazon, but they're really great for both muscle and tendon deep massage. Eccentric exercises, very important, and steroid injection or PT modalities, some things that that physicians can prescribe by physical therapists. Ultrasound is one of them. They can also do some steroid electrophoresis and some heat cold treatment, some other things. Steroid injection, there's a lot of controversy around steroid injections, that steroids can weaken what you're trying to treat, so if you keep doing it, whatever you're doing, and you get a steroid injection, you can actually make it worse. As far as eccentric exercises, that's primarily useful in like tendinosis of the forearm muscles, very common in paddlers. Has anybody here had that before? Tendinosis of the forearm?
Like where my entire
fingers are cramping.
Yeah. Yeah, pain in the forearm with paddling or after.
lose my grip entirely. I
Yeah.
associate that with what I would call tennis elbow, which is from the heavy impact, right? Like,
Well, that is a form of it, but you can also get it in the extensors and the brachioradialis, which is the back of the arm.
yeah,
Yep.
yeah.
So, yep. So it's a common problem in paddlers that paddle a lot. Yes.
I know, like, they used to recommend alternating, like, ice and heat. Now they
Yeah.
mostly recommend ice. Is that right?
Acutely, you want to use ice. You can use some heat therapy after like the first couple of days, but right after you injure it or right after you aggravate it, you want to stick with ice. Like a couple of days later, you can use some heat. The ice is supposed to basically slow blood flow to the area, which adds to the inflammation aspect. So you're trying to calm down that inflammatory response. Whereas when you use heat, you're trying to increase blood flow for healing. So you have different effects. As far as eccentric exercise, very useful for a forearm injury is, let's say I have an extensor tendonitis, then you would put like a dumbbell in your hand and lift it up with your other hand, like you have it laid on a table, and then you basically let it lower slowly, so you're firing the muscle as it's lengthening. Very useful for tendinosis.
How big a dumbbell?
I would say a weight you can do about 10 to 15 times before fatigue.
How heavy a dumbbell?
It depends on how strong you are, but around 5 pounds or so.
So 50 for
Yeah. For some people it may be 2 pounds, for some people it may be 10 pounds, but strain, typically at the muscle injury. Prevention, same thing as the tendinosis. Technique, strength, warm up, stretching. Treatment is very similar. Massage is very beneficial for muscle injury. Okay. So prevention of sprains, again, technique then strength. Treatment, immobilization is important for sprains. Think of like ankle sprain. You want to immobilize it briefly, and then when it's pain-free, you can start using it again. Sprains are of the shoulder. You would want to put it in a sling, and till it kind of calms down, then you can like slowly return to activity. For complete sprains, sometimes surgery reconstructs the ligaments. It's rarely, but sometimes done in shoulder separation injuries. Also, rarely, sometimes done in ankle sprains. Okay, so rotator cuff. You have acute and you have chronic. Primarily, for acute injury, it's something traumatic, a sudden force, sudden impact, too much force that the rotator cuff can bear. You end up tearing usually the tendinous part of the rotator cuff where it goes over the humeral head and attaches to the arm. I mean over the humeral head where it attaches to the humerus. You can also have chronic tears though, common in folks laborers that do repetitive stuff over and over again, primarily overhead, like painters, that are painting overhead a lot. They can get tears in their rotator cuff. People that are doing heavy lifting over and over again, they can get tears over time. Prevention technique, trying not to isolate a specific part of the rotator cuff, trying to use good form, that's especially important in paddling. Also, strengthening the rotator cuff is thought to be beneficial. Okay. So, rotator cuff tears are diagnosed by a history of an event that could cause the tear, physical exam, and MRI to actually visualize the tear. You can be very suspicious of a tear by physical exam findings. But the only way to prove it is to do the MRI. Or you could also do endoscopy, look at it directly with a scope. Treatment, initially they're treated conservatively. Physical therapy, rehab exercises. What you're trying to do there is you're trying to strengthen what's remaining of that particular rotator cuff, as well as the supporting extrinsic muscles to kind of give additional support to that injured tendon. Surgery is kind of a last resort, and rotator cuff tears don't heal. You either rehab enough to get whatever function you need for your activity, or you have to get it surgically repaired. So now we're going to talk about the dislocation of the shoulder. This is a normal shoulder, and this is an anterior dislocation. You'll notice that the head is actually lower, and it's sitting in front of the glenoid. When you look at someone that has this injury, it's pretty obvious, especially when you compare it to the other shoulder. You can even see here on the X-ray a nice rounded deltoid here that you typically associate with the shoulder, and you see that the acromion here kind of sticks out and forms with the step off that you see with the anterior dislocation. The humeral head isn't under it anymore. So, as in this photo, this is the normal shoulder on this side, and you can see that step off of the acromion sticking out, and the humeral head is sitting down here. The other way you can tell is they will not be able to put their hand on the opposite shoulder. They generally are holding a position of comfort, which is the sling position, and they don't tolerate much motion. So you can either fully dislocate or sublux. A subluxation is when it kind of comes out and then pops back in immediately. When you have that injury, you're going to have pain. They're going to pretty much feel like that they have done something pretty major to their shoulder. They're not going to tolerate much motion with it. It's going to be pretty sore. General, the dislocation move is abduction, extension, and internal rotation. So when the arm gets behind you, abduction means away from the body. External rotation is, extension is behind you, and external rotation is like this. So when this is basically the position we're talking about. The arm behind the trunk and extended. Paddlers, generally it's poor technique, sudden stress, weakness in the cuff. We're going to talk about maintaining the box. And maintaining the box is having your humerus in front of your trunk, not behind your trunk. You make a square with the paddle, your trunk, and your forearms. That's called the box. Anytime you get outside of that position, you put your shoulder at risk. Consequences: you can have soft tissue injury of nerves, blood vessels, also being damaged. You can have chronic instability. It's almost always the case after a dislocation. That shoulder is going to be lax. They're going to not like it when it's stressed in the anterior. When you push that humeral head, try to push it back like you're going to dislocate it. That's one of the exam findings that let us know they have laxity and apprehension. You can have a fracture. Hill sacks is a common injury to the humeral head. Makes a little dent in the head as it slips over the acromion. Over the glenoid. And of course, we're going to talk about rotator cuff injury as well. Generally, you can have laxity of the capsule, which is, the part that surrounds the humeral head. You can also have a tear in the rotator cuff and stretching of the rotator cuff. So these are stolen from NOC instructor blog website, basically demonstrating good and bad positions of several key components of paddling. Sweep stroke, we have a good sweep stroke. We have you notice that the paddle is pretty close to being aligned with the trunk, that the humerus is in front of or in line with the trunk. And then on this side, you can notice that the trunk is more rotated away from the paddle. The humerus is behind the trunk, and his head is turned in the opposite direction. Sweep roll, pretty much the same thing. A good sweep roll, you want to face the paddle or face the paddle blade. If you come up like you're going for air, carping it, or even looking forward, and you're letting that paddle get behind you, you roll up, you get knocked over by a wave, unexpectedly, that paddle's behind you, you're in the dislocation position. So not only does facing the paddle blade help protect your shoulder, it also greatly increases your chance of actually rolling up. So common misconception in boating is that low braces are good and high braces are bad. Actually, both can be bad or good, depending on the technique. The high brace position that's good, you notice that the elbow is low below the shaft of the paddle. He's aligned with the paddle, and notice that the humerus is going down and not up. And in the high brace position, a bad high brace is basically the paddle over the head, classic. You've probably seen people doing this on the river all the time, but that's a very vulnerable position for dislocation. Yes.
When you say low brace and high brace, are you talking about the traditional concept of a high brace being using the spoon face of the paddle and the low brace being using the back face of the paddle? Is that correct?
Not necessarily. A high brace is pretty much that the elbow is below the paddle shaft, and it could be instead of above or behind the paddle, like this.
Okay, so that's how you're referring.
So elbow is below the paddle shaft, and the elbow is bent. That's the other key thing. The high brace, a bad high brace, the arm is straight and up. So low brace, elbow is bent and low, and the forearm is level, as opposed to being down, which is a bad low brace. Because when you push the paddle down in this position, it moves the humerus up. Whereas if you keep the elbow down, the humerus is in the adducted position, close to the body, where it's safer. Does that make sense?
Yeah.
Okay. All right. So I'm going to go over that one more time. So the box. I don't know. Anybody have a paddle? You have one? Oh, okay, cool. All right, go ahead and get the paddle. We'll move on, and then we'll come back to it. Advantages of reduction in the field. Pain relief is a big one, especially if you're out somewhere. Evacuating someone with a dislocated shoulder is extremely painful. Every little step, every little bump just is excruciatingly painful when that shoulder is not in the socket. They're much easier to reduce if you do it as soon as possible. The longer that shoulder's out, what happens is the rotator cuff muscles spasm down due to pain, and then it becomes an ordeal. drugs are involved. I'm just going to have to yell. Oh, you got? Oh, cool. All right. So, low brace. There we go. Oh.
Wes,
You got it.
All right. There we go. Low brace. The elbow is bent. The humerus is low and close to the body. High brace would be like this. The elbow is also, the humerus is still adducted or close to the body, but the paddle is above the elbow as opposed to in front of the elbow. So like if you fall into like a hole, sometimes if it's a high hole, it's kind of hard to do a low brace, but you can still do the high brace to get your paddle on top of the water as long as you keep this elbow low and close to your body. Does that make sense? Low brace is like if you're about to flip, you throw down a low brace, then you want to keep it close to your body and the paddle low. As far as when you come up from as far as the sweep stroke, you want to make sure when you do a sweep stroke that you're turning your trunk with the paddle, as opposed to leaving your trunk forward and head forward and pulling the paddle behind you. Okay, you see this on the river all the time. Just watch people. You'll see them all the time. They'll look like over here doing a sweep stroke and they're in a vulnerable position. Whereas if you just turn your core, what you should do when you paddle anyway to have a good forward stroke, you should turn your core with the paddle. That maintains the humerus in a safe position. And then coming up from the roll, when you come up, you want to make sure you're looking at the paddle blade, as opposed to going up for air. You see the difference? Watch what my elbow does when I go up for air, as opposed to looking at the paddle. You see the difference? When I go up for air, my arm straightens out, and if that goes up, it's out. Unexpectedly knocked over by a wave when you're rolling up, it's out. Does that make sense?
So is it okay to do like a sculling brace if you turn your body and kind of...
Oh, absolutely.
Okay.
Absolutely. A sculling brace is fine as long as the position is good. The elbow basically low. Okay. Yeah. And of course the bad low brace I didn't show you, but that's where you'll see this too. Where you'll see people like throwing a low brace and you'll see their elbow come up sometimes. That's a vulnerable position because of where the humerus is. If you see my humerus is up, and all it has to do is get an unexpected kick and it's out. That makes sense? I highly recommend going to the NOC instructor. Just Google NOC instructor blog post shoulder and it'll pop right up. And it's very important, I think, to not only for ourselves to know this, but when we see new boaters, especially when we're doing instruction, this has to be hammered in from the get-go. Because once they develop a bad technique, it's very hard to kind of get it out of their head. So, all right. So, going on with the advantages of field reduction. If you do have to evac them, it's much easier to evac them after reduction. Much less painful. They can walk, much more comfortable, and also there's less chance of further injury. Okay, so the risks of reduction in the field, it's possible to cause further nerve or vascular injury, and if there is a fracture, it's been misdiagnosed. It is possible to make that worse. I will say that it's pretty hard to fracture. It's pretty hard to cause a significant fracture by basic paddling. Generally, when you worry about fractures, it's like falls, scouting falls, top of a big rock, fall down, shoulder injury. Then you have to consider at that point, since it was a traumatic fall, if they actually broke something rather than just dislocated it. That might be a situation where if somebody had a dislocation after a fall, I might consider not reducing that. But that would be a judgment call. The risks of reduction in the field generally are far exceeded by the benefits. Complications are extremely rare. Anybody listen to hammer factor? Louis Geltman on hammer factor had a very unusual injury. Somewhere back in the day, he had a dislocation, and actually he interrupted his blood supply to his proximal humerus, and he has actually avascular necrosis of one of his shoulders. That's where when the bone supply gets interrupted, the bone just kind of erodes away. That's exceedingly rare. I mean, that's the only case I've ever heard of in a paddler. Out of all the dislocations I've heard of people happening paddling. And it's actually, I've never seen one in my practice of an avascular necrosis after dislocation. So it's a very rare injury. So reduction techniques, we're going to go over next, and I need a volunteer. Oh, yes, Rob.
Do I need to put down my beer drinking arm?
Yeah, you will actually. I'm trying to think, find a, let's bring this table up here.
Cool.
We'll need the table. Oh, sorry. If you have somebody else there, it would be awesome if you get the other person to actually do that while you're doing the reduction. Have somebody actually behind them, kind of steadying them and trying to massage those muscles and coaxing them to relax. So you take the arm, and they're going to be holding it like this, okay? So you tell them, I just want you to relax. Just relax those muscles. Let everything go soft. And then you slowly, externally rotate the arm as you're pulling down gently on the elbow. You don't have to pull hard, but you're pulling down pretty gently on the elbow as you're externally rotating it. And if you feel a clunk, it's probably gone back in. My only reduction on the river went in pretty quickly doing that right after the injury happened. He'd never dislocated before. If you can try that a couple of times, and if you're not getting results with that, then I would move on to the Milch procedure. The Milch procedure, they have to be lying down. So lay down on the table.
All right.
Yeah, there you go. Your feet that way. Yeah, there you go. So you can actually do the hennepin with them lying down, but the only problem is you can't massage those muscles doing that. So I'd probably have them sitting up and trying the hennepin technique, and then I'd move on to the Milch. So with the Milch, you take the arm, you kind of move into the, as you were doing in the hennepin, you might try it one more time, and then you want to move the arm up and over the head. What you're basically doing is you're moving it into this position, and you're pulling on it with traction. So what you're trying to do is you're trying to rotate that humeral head from in front of the glenoid back up into the glenoid as you do that. So external rotation, like we did with the hennepin, and then pull the arm up just like that. I've used that successfully, the ER, a few times, but that would be step 2. Step 3 is called the Stimson maneuver. Always works. So turn over on your belly, head that way. There you go. All right. Cool. So obviously doing this on the river is going to be complicated because they have to be lying in the prone position. They have to have enough room for the arm to be straight and straight down and not touching anything. Maybe you could stack up some boats on top of each other or rafts. Find an appropriate rock. There's going to be some places where this is going to be difficult to do, but just try to think of a way to get them in this position so their arm is like free hanging. And so what you want to do is you want to attach some weights to the lower part of the arm. You can use rope, you can use webbing, duct tape, but you want about 5 to 10 pounds of weight. Duct tape would be awesome. You can just duct tape rocks to their arm, I guess, but if you could put the rocks in something like a throw bag and then do that, would probably be easier. But you want about 5 to 10 pounds of weight, and you want to just let the arm hang with that weight on it. Now what that does is it fatigues the rotator cuff. That rotator cuff can only fire for so long. Generally they say 10 to 20 minutes. In my experience, depends on the strength of the person and how much weight I have on them. But this has never failed anywhere. ER is the only place I've done it, but it's never failed. What you can do to accentuate this technique is called scapular manipulation. So if you feel on their back, you feel for the scapula, you feel for that little triangle on the bottom, on the wing, and you'll feel it as a little rounded corner. You could probably find it on yourselves or somebody else. But you want to take that little rounded corner and you want to rotate it towards the spine. And what that does is it turns the glenoid over towards the humerus that's just hanging there by that weight. And it helps it to slip back into place. Generally when you do that, they'll feel a clunk. You may not feel it because you're not directly interacting with the extremity, but they'll feel it like clunk into place. So you just you could just grab that edge with your thumb or fingers and you just rotate it. You feel that?
Yeah.
You're just rotating it towards the spine. You're pushing it that way. Does that make sense? Everybody getting that?
What muscle is that?
That's the scapula bone.
Oh,
It's your shoulder bone.
Yeah, he's grabbing my shoulder.
The bottom part of it. You know, it's shaped like a triangle.
your angel wing.
Yeah, it's shaped like a triangle, and the bottom part is kind of a rounded point, and you feel for that point, and it's sitting right below the shoulder on the back. You can follow the edge down. You can actually follow the edge down from the shoulder and find the bottom of it. And you just grab that edge that's towards the shoulder, and you just rotate it inward. Sometimes you can actually do that and put it in place if you just have someone like just pulling on it. Like you can have them seated, and someone could be like pulling their arm this way. You don't have to pull really hard, and then somebody behind them can be pulling that scapula around. Does that make sense? So you're basically rotating because the glenoid is sitting in front of the scapula in dislocation. So you're rotating that glenoid so that it allows the scapula to pop back in there.
So Wes, my uncle taught me that one thing you could do instead of doing weights around your arm is to lean back with your fingers interlocked.
That's the self-reduction technique. I've never heard of this being done successfully in a first-time offender, but certainly in folks who have, it's worth trying. If you've got a stoic person, that absolutely worth trying. If you're kind of afraid to get involved, you could absolutely try to coach them to do this and show them what you did.
Yeah. So just interlocked my fingers, wrap my hands around my knee, and lean back. And I can kind of feel like 5 to 10 pounds of pressure on my shoulder pulling me forward, just as if I was face down with weight on my arm.
Right. And maybe you can do some scapular manipulation while they're doing that to kind of help them out. But yeah, that's something I've heard of being done, particularly in folks who have lax rotator cuffs, who pop their shoulders out all the time.
And this guy had.
Yeah. So yeah, don't do the Mel Gibson slam against the wall. I do not recommend that technique at all. But yeah, self-reduction. That's definitely something to try. Even if they're a first offender and you're kind of queasy about doing it, or you're not really sure what to do, you could always suggest that. It may work. And again, if you just stand behind them and grab that scapula and try to rotate it back towards the spine, that may aid to the success of that. Give them a little help and get it done sooner. But yeah, it will eventually work. If it's a really big person, with really strong shoulders, you might need more weight. 15 pounds or 20 pounds. Another thing I forgot is another way to attach that weight is to take a helmet and put rocks in it. And I do not recommend them holding the weight because it's hard to relax when you're holding something. But you want to try to find a way to attach it to the wrist so they can actually relax their whole arm. Does that make sense? Yeah.
Outside of obvious visual angulation, what could you do to determine that mechanism of injury, of course, but what would you determine that you probably don't have a fracture, therefore it's safe to go ahead with a relocation procedure?
Unless the fractures we're concerned with are proximal humerus fracture. Also, you could have acromial fractures. You can have, which is that bony process that sticks out in front. You can have scapular fracture. You can have clavicle fracture. as far as, you're not going to make anything worse by doing a reduction while you have a clavicle fracture. You're not going to make anything worse by, the only thing you can make worse is if you happen to have a proximal humerus fracture and you start pulling on it. If they have, I've heard of a story where somebody thought they dislocated, but after a fall on a river trip, but it was actually a shoulder separation. And that's where the ligament that attaches the clavicle to the coracoid process, the top of the shoulder, this little bump right here, that's where that gets sprained. Common on falls on the shoulder. It's called the quarterback injury. They get them all the time when they fall. But at any rate, if they're tender right there on that bony process and not anywhere else, that's the injury. And the story was that this person went through an excruciatingly long period of trying to reduce the shoulder that wasn't dislocated and making this agonizingly worse. Didn't make the injury worse, but it was a long, painful, unnecessary process. So, you know, I think the story was they didn't bother to take their dry top off to actually look at the shoulder, and they assumed it was dislocated. But if you look at it, as in that picture we showed, it's pretty obvious that shoulder don't look like that shoulder, and you have that step off. And they can't put this hand on the opposite shoulder. Those are key signs you have a dislocation.
On Sunday we had a river dislocation. I tried to reduce Cooper least. I took my finger and I stuck it in the squishy part, like the socket.
Yeah.
Like, did I mess up? Or did I put him at risk? And the other thing I did was I felt behind his armpit, and of course I could feel the humeral head.
Yeah.
I could feel like the big knobby bone right there in his armpit. It shouldn't be in his armpit.
Right.
But I did know to check and make sure that it wasn't an AC separation. This could be both. But,
right.
Is there any risk? You know, like what could I really screw up and do? Because I didn't want to take his dry top off.
Well, yeah. I mean, you could probably actually palpate it, you know, through the dry top, that step off. So
it's really squishy. Like it's kind of gross.
Yeah.
Sorry, Cooper. I'm gonna watch this one day.
You'll laugh about this one day, right? All right. So post reduction, sling is generally recommended. If you don't have a sling, you can actually, if you have like some form of, you can use duct tape to make a sling. But if you have like some kind of wrap or cloth, you can actually make a figure 8 out of that around the trunk and around the arm. All you're trying to do is basically hold the humerus against the body. You don't have to hold the whole forearm, just the humerus. So one benefit of doing that type of immobilization versus a sling is they still have use of their hand. So if it's somewhere where they have to kind of, you know, hold things or climb in that situation, it's advantageous to have something to kind of hold this in where they're taking the whole arm out of the picture. I've actually had a reduction on the Russell Fort that paddled out. I kind of left it up to him. I said, you know, just keep your arm low, and he did fine. But I'm sure it was painful, but you know, he basically weighed that option versus hiking out, which is where we were, would be a really tough, you know, hike out. And I always recommend orthopedic follow-up. You don't know, you might have had a Hill-Sachs lesion, which is a dent in the humeral head where it slips around the glenoid, and they generally, that's when you have that lesion, they tend to treat your rehabilitation a little bit different to give that some time to heal. They don't push you quite as aggressively, so it's good to know that you have that lesion. It doesn't need any like surgical repair or anything, but it's just, it kind of just changes the rehab picture. So now we're going to talk about shoulder. Hey, Rob, I'll put you back up here. We're going to talk about shoulder rehab and strengthening. There's tons of these again all over the internet. Let me have you lay like face down again, like with your head down here. All right, so Some of these are done with like elastic bands. You can get like you can get TheraBand, which is like different grades of flat latex, or you can go to Home Depot or Lowe's and get some surgical tubing or latex tubing, and you just vary the resistance by how long it is, or you can double it or triple it. But the first one I'm going to talk about is prone flexion. So that's where you have like a dumbbell in your hand, and you have, or you could do it with resistance, and you're basically moving this hand forward, moving it up towards the head. You keep the elbow straight, and you're rotating it forward. Obviously, you can do that standing up as well, but it just it puts the shoulder in a better position if you're doing it prone. Prone abduction, same position, and you're taking the dumbbell and you're moving the arm out away from the body, just like that. Prone extension, you want to move the arm back like this. Okay, so this, imagine I'm laying down. So you have flexion, abduction, extension. Everybody got that? Okay. So another one is prone scapular stabilizer, and that's where you take, basically you raise the arm up till it's like in line with the body. Turn thumb up, and then you want to raise this. You want to continue to raise it up while you keep your body flat on the table. So what you're doing is you're squeezing your scapula against your spine. Does that make sense? Your rhomboids that stabilize the scapula on the medial aspect. That's the muscles you're working on this.
I can really feel that tight in my shoulder.
Yeah,
blade.
That's definitely it. Then there's a prone scapular retraction, and that's almost the same thing, except you're doing both arms. Yep.
That?
Yeah.
All right.
There you go. Okay, so now I want you to lay on your side.
Yep.
Lay on your left side.
Yep.
All right, so the next one is external rotation. So that's basically, that's basically what he's doing. You start out level and you turn like this. Yep. And there's an upright version as well. We'll talk about in just a minute.
You normally put a pillow right here, and would you do this with a TheraBand, or would you do this with like a 5-pound dumbbell?
You can do it. You can do it with a dumbbell, or you can do it with a band. But you want to actually keep your elbow against your side.
So I want to.
All you're doing is rotating this.
My arm all the way in,
Yep.
and keep it in tight.
Yeah.
And
Yep.
should I feel that in my shoulder blade, or should I feel that
You're feeling it actually in the
in my
shoulder
rotator
itself.
cuff?
Yeah.
Yeah.
Yep. You're feeling it in this You're feeling it in the rotator cuff.
Yeah. So
Yep.
if I do this two different ways, like sometimes it gets really sore up here, and sometimes
Yeah.
it gets really sore back here. And it's like,
Yeah.
which one does it do first? So what am I going for?
All you're doing is you're strengthening your rotator cuff. So you're not.
Which one should I be targeting with this particular exercise?
Well, if you keep your elbow in and you're purely rotating the humerus, you're only targeting one muscle. Well, a little bit the deltoid, but primarily you're targeting the rotator cuff.
Yeah. Okay.
Next one is supine shoulder protraction. So lay on your back.
Yep.
And raise your arms straight up like you're sleepwalking, and try to keep your spine like solid on the table, and then push your arms forward. That's protraction. You can do it with weight, obviously, or just weight your arms until you get strong enough. Now I'll have you sit up, or actually I'll have you stand. So supraspinatus raises, we also call that the empty can. The humerus 45 degrees away between the plane of the trunk and forward. Thumb down, and you raise it up. That isolates the supraspinatus muscle. So you can put a dumbbell in your hand or stand on a band. This is the most important muscle to work if you have if you have anterior instability, which is like after a subluxation or dislocation, this is the muscle that is most important to strengthen. The next one is the external-internal rotation while standing. So elbow at the side again, put the band on a doorknob or tie it to something. And the external rotation is moving out. Internal rotation is moving back across. So out and back across. Let's see, and push-ups, that's the last one. And everybody knows how to do those. And I think that's it. Yep, that's it. Any questions? Yes?
Do you recommend any warm-up stretches or anything before you paddle?
I generally don't stretch. It's probably okay to do some light stretches. Stretches in the shoulder can definitely be overdone though. You want flexibility, but you don't want to kind of instigate laxity. So I would say, how you stretch like other muscles of the body, how you really push those stretches, I wouldn't do that with the shoulder. I would just go through like a range of motion. There's people, you can actually hold a paddle and you can like go through like the different motions that you have when you paddle, like stretching overhead, leaning back. I've seen, who's it, Fred? I think Fred Wilson actually takes his paddle and goes all the way behind him. I don't do that, but that's something I probably would not recommend doing because I think it puts too much stress on the shoulder. But I would, with the shoulder, I don't think stretching is as important as some other joints, but definitely a good warm-up is important, I think. Where before you like, if you put it on a river and you're going to have, hard rapids, you're going to be stretching your shoulder on downstream, you want to get a decent warm-up. Sometimes you can get it just doing the paddle leading into it. Some places you put in, you're on top of a class 4 rapid like Tallulah. And it's kind of hard to get a warm-up there, but what I do at Tallulah is I just do some ferries, like at the put in. Just do some ferries and some like attainment and ferries, and just till I get my muscles, fired up and ready to do the workload. But as far as stretching, I would take it pretty easy on that, as far as the shoulder is concerned. Any other questions?
Posterior dislocations, would the techniques be any different?
Oh, posterior. Posterior would be pretty impossible to do paddling, but they're rare, and they're generally due to a acute traumatic injury. The last one I had was just a fellow that fell forward and caught himself with his arm. He's kind of an older fellow. Yeah, you can see them in motor vehicle accidents where they're gripping the steering wheel and they have a big impact. But they're generally due to significant trauma. It's a much harder to do, and the reduction is actually pretty similar. You're instead of pushing, you're actually pulling this way, just like forward, say along the axis of the arm, while they're like laying down. But it's not a hard reduction to do compared to anterior, but it's pretty hard to diagnose in the field actually. You can strongly suspect it by the mechanism of injury. Fell off of a rock, landed on their arms, can't move their shoulder, but it would be really hard to rule out a fracture. So if you did not have a classic anterior dislocation, I would just immobilize them and get them out. Other questions? Anytime you guys see me out and about and you want to go over anything, reduction techniques, grab me. I'm always open to it. I recommend, again, watching the videos online. You can actually get references for rotator cuff rehabs online, and I do recommend strengthening the rotator cuff. And I recommend thoroughly studying the NOC Paddlers blog on shoulder safety. And if you want to If you want to thoroughly hammer in the techniques of reduction, I recommend Googling these different techniques and just watching videos. Watch the videos over and over again, and you'll say, oh, I can do that. So, any other questions? Okie doke. Thank you.